Hello, everybody. Thank you for joining us here today. My name is Mark Vanderhulst. I am the marketing director for the point of care ultrasound business in the US here at GE HealthCare. And we are incredibly excited to be partnering with AMSSM to be able to bring you today's educational webinar, talking a little about how ultrasound could be used in ankle ligament laxity assessment using ultrasound. So I'm incredibly proud to be able to introduce Dr. Brian Heiderscheit, PT, PhD, UW Health Physical Therapist. He has his doctorate in biomechanics and advanced expertise in orthopedics and rehabilitation. Brian's also a professor and vice chair for research in the Department of Orthopedics and Rehabilitation at the University of Wisconsin School of Medicine and Public Health, as well as the director of UW Badger Athletic Performance. Brian has a lot of experience and expertise in treating sports and running related injuries in athletes of all ages and activity levels, and he diagnoses and treats knees, joints, bones, stress injuries, and overuse injuries, such as Achilles, swelling and pain in tendons and muscles. So without further ado, I'm going to go ahead and kick it off to Brian, who's going to kind of give us the meat of the presentation here today. If you have any questions, comments, concerns about what's going on, please make sure you're firing off questions in those comments. We are going to have some opportunity at the end to kind of address any sort of the questions. So any questions that you have, please go ahead and put those in the chat, and we'll try to address those when we have a little bit of time at the end. Without further ado, I will kick it off to Brian to begin today's webinar.
Thanks, Mark. Appreciate it. Again, thanks everybody for taking the time out of your day to join. I know on Mondays it's usually pretty tough to get back and carve time out, especially in a busy clinic practice. So hopefully this fits in well. I've prepared a handful of slides to really kind of talk through this issue that we put a little more time in as of late, which is really thinking about how we can leverage ultrasound imaging, both at the point of care, but also in the sense of, from a research standpoint, of using it to understand more about ankle ligament laxity, particularly after a lateral ankle sprain, which is, as you know, one of the most common injuries that we face across a number of sports. So today's webinar really is designed about how we can utilize that ultrasound imaging at both that point of care, as I mentioned, or in clinic setting where we can be able to get a better understanding of both the prognosis and plan of care for these injuries. Quick disclosure slide. All right, so when we dig into ankle sprains, and again, I don't want to belabor the background too much because I think we're all very, very familiar with these, as it's usually one of the most common and most frequent and one of the first injuries we've ever experienced ourselves, as well as within our patient volumes. But we see these as being extremely common, again, across a number of sports. And while our management understanding of this injury has definitely improved over the years, nonetheless, it still remains quite common and one that again, we learned very early on in our training. And one of the concerns with this injury is not only obviously its prevalence rather, but its high rate of re-injury. And if the high re-injury rates, of course, relate to the exposure, but also the issue of remaining deficits that persist from the original injuries, such as the amount of joint laxity, and then oftentimes what we determine as being chronic ankle instability, or CAI, is something that has been well documented in the literature as being an ongoing issue that persists well after the injury itself and can persist in up to 70% of individuals can go on to develop this and then ultimately potentially have risk for long-term issues such as osteoarthritis and persistent dysfunction well into their later years. And so when we think about trying to image these on scans, and again, I'm going to put a variety of different images up throughout today's webinar, really for those who may have more or less experience using ultrasound for the imaging purposes, just to review some basic anatomy as well. So when we're thinking of these injuries, the ATFL, or the anterior talofibular ligament, is by far the most commonly injured ligament when in lateral ankle sprains. And so the image on the bottom left, the ATFL shows very clearly, I think, on the scan, where we have the fibula located and the talus, and then the location of the ligament running between those two structures very cleanly. And again, a couple of other ligaments are also shown on this slide, including the calcaneofibular ligament running between the fibula and the calcaneus on this end, and you can see the ligament in between the two. And then also the fibula and the tibia showing the anterior inferior tibiofibular ligament, and again, running between those two ligaments. So we can appreciate that there certainly is a ligament that's present on these images. And as we'll see in a little bit, how well does ultrasound identify any sort of disruption in these ligaments following the injury? And then how do we think about trying to measure the amount of laxity or instability that can be present? So when we look at some of the most recent clinical guidelines that have been recommended with regard to management of lateral ankle sprains, one thing that has become clear, and that is early progressive loading post-injury is absolutely encouraged over a standpoint of just immobilization during this early period. We want to get them up and moving as soon as we can. But interestingly, there want to be a little bit of a delay in ligament testing. And again, the idea of trying to test the ligament at the time of injury versus waiting 4 to 5 days post-injury, that little bit of waiting period tends to give a more reliable and accurate assessment of the amount of ligament damage that may have presented. And so the sensitivity, the specificity of your physical exam test, whether it's an anterior drawer, whether it's a reverse anterior drawer, whether it's the tilt test, tends to be better roughly 4 to 5 days post-injury. And so when we think then about imaging guidance, it makes sense that about that same point in time may be most suitable as well for some of the imaging, X-rays being reserved for really when you're thinking about from a fracture standpoint, MRI typically for more severe or complex cases, especially when we start wanting or concerned with an osteochondral defect or a syndesmotic type injury. But ultrasound tends to be very useful and is rapidly emerging as the go-to for targeted diagnostics near the point of care with very good sensitivity, specificity a bit lower than ideal. But again, this shows itself to be the most emerging way for us to be able to get a good sense of the amount of tissue damage and the severity of the injury. So what can we really see on these ultrasound images? And again, I think importantly, the typical clinical ultrasound image or evaluation does very well at assessing the severity of the tissue injury, but it may not be able to quantify the amount of joint laxity as well. And we'll walk our way through this idea a bit. But these are some very good sample images from a recent paper that looks at in the upper left in the A panel, where we can see normal ligament echogenicity and clear fibrous texture between those two structures again for the ATFL. Versus if we look at in B, where we have a mild sprain, you can see a little bit of thickening that's begun to present in the ATFL. Echogenicity is a little bit reduced into that region, but good ligament continuity. So again, not the point of being a rupture, but a bit of a sprain, a little bit of tissue damage, blurred fibrous texture, but overall representative of a sprained ligament. The C panel, then we begin to see a partial tear develop, again, thickened ATFL, and we start to see some interruption and discontinuity in the deep ligament with some anechoic regions and hypoechoic regions in this deeper portion where the partial tear is located. And then finally in D, we see a complete tear, which is your interrupted ATFL throughout its entire substance with that anechoic and hypoechoic regions illustrated. And then the panels E and F show some further variations with complete tear with an avulsion and then some other variations of a similar structure. Now, again, if we were to test this on our physical exam, doing a drawer, I mentioned the reverse drawer, we may be able to identify an extent of laxity. We may grade it as a plus or a minus. But does that give us enough resolution or precision to be able to make the concern or the extent of how this patient will be long term, and will they be successful in being able to hopefully prevent some of the AI or CAI, the chronic ankle instability features that are so too common to present themselves, but also what's the likelihood of a re-injury, and maybe that laxity and the extent of laxity is one of those predictors of these re-injury risks that we're concerned with. And so again, the physical exam, as I mentioned, is something that's oftentimes done, even if we delay it 4 to 5 days. We'll be able to identify what we appreciate as being a side-to-side difference in the amount of laxity or instability at the ankle, whether we do an anterior lateral drawer or what's become more common as of late using a reverse anterior lateral drawer, mainly because of the ability to stabilize and apply force in a more directed way in the reverse setup. Tends to be helpful. Now, what if we combine these two? What if we think about bringing ultrasound with a reverse anterior lateral drawer? Does that enable us to actually track the extent of displacement between the fibula and the talus to an extent where we might be able to identify re-injury rates and those who may have difficulty coping with the amount of instability that may persist? And so digging through the literature, you'll notice that there's one paper from a little over a decade ago that did utilize loading of that structure of between the lateral malleolus and the talus, so the loading the ATFL under two fixed loading conditions. So one was a no load condition on that left, a 0 Newton stress was applied, and they drew the distance between the point on the talus and a point in the lateral malleolus, and they looked to see how did that change if we then took that same structure and put it under 125 Newton stress position, or load rather. And so now we can see the amount of displacement of the ATFL in the no load versus load scenarios. And does that allow us to reflect what the examiner identifies during their graded tests? Unfortunately, this sort of testing procedure becomes challenging. One, 125 newtons is somewhat arbitrary and likely insufficient to assess the full extent of displacement. But then two, it's difficulty because of these way these lines are drawn to reflect the length of the ligament to ensure consistency from one frame to the next, from one image to the next. Are you on the same fixed points on the bone? Is the plane of imaging the identical across the capture between these two load conditions? So it becomes somewhat challenging to be able to assess this and determine its value. And so here at the University of Wisconsin, through our Badger Athletic Performance Program, just to introduce ourselves a little bit here, this is a joint program between the Department of Orthopedics and Rehab, which is my home department, as well as the University of Wisconsin Athletics, where we developed a joint venture created as Badger Athletic Performance, which allows us to really try to advance the science and care of the athlete, both in terms of their performance on field, but also in terms of their overall musculoskeletal health. And this has led to a number of different research programs, as well as industry collaborations to really try to advance this work. You probably recognize several people on this slide. Several are members of AMSSM. And again, our work spans a number of different areas, whether it's running related, muscle tendon, post-surgical recovery, and certainly ankle sprains falls under this area as a big area of interest of ours. And so through our group, through our team, this has become an area that we've wanted to understand a bit more, is using ultrasound imaging in combination with, in this case, the reverse anterior lateral drawer test. Can we begin to measure the displacement between the talus and the fibula directly through the integrity of this ATFL? So we can certainly appreciate the quality of the ATFL ligament, but how do we truly be able to assess the amount of displacement that we might have occurred from the injury itself, rather? So what does this look like? So the upper right is showing you a cine loop that's recorded during the reverse anterior lateral drawer. You can see our ultrasound settings on the bottom left that we traditionally use. We capture at a frame rate of 53 frames per second during the cine loop, and we apply the examiner force, as you would for the reverse anterior lateral drawer test, by preloading for 3 seconds, loading and stabilizing and holding it consistently at that applied load for about 3 seconds, and then gradually reducing that load back to your baseline levels. And so that's what you're seeing in the video up above, the preload, holding it continuously, and then reducing and returning back to your pre levels. And so this is in a healthy ligament, and we can't appreciate a whole lot of displacement that's happening between the talus and the fibula. But we do see a little bit here. Now, generally, it's going to be less than 1 or 2 millimeters that we're going to identify in a very healthy ligament. And so what does this look like from the actual acquisition? So here we have a full video. So we have our patient on the table lying supine. The knee is going to be oriented to about 30 degrees of knee flexion. We're using the GE Venue Go system located here with the linear array transducer, the hockey stick, as it's typically called. And you'll notice how it's oriented here, where we place the heel at the lateral malleolus, the heel of the transducer at the lateral malleolus. And then we orient it along the location and the anatomy of your ATFL. And so you'll see it come up here on the screen pretty well. There's your lateral malleolus on the video, and your talus is located out by the toe region and showing up on the screen through that location. And then as it's pulled off and it's complete. So it's a fairly quick process. And again, the load sequence is that 3 seconds of preload, 3 seconds of actual loading and performing the reverse anterior drawer to its max displacement, 3 seconds of unloading. Now we're going to repeat that again using a different probe because you actually don't need a system like the Venue Go to do it. It provides better resolution, better screen image, but you can also use the V-scan as well if you're on the go or you're away on a traveling situation, for example. The V-scan image will allow the same sort of acquisition for both the talus and the fibula, and you can orient again yourself to where that ligament is. He's going to do it a few times here. This is now Ito, one of our postdocs, physical therapists here at the University of Wisconsin, part of Badger Athletic Performance, and reorienting a few times. I'm gonna zoom into some of these images, but again, you can see the capture point is fairly well maintained throughout that application of force for those 3 seconds, holding it for a max of 3 seconds, and then unloading it for 3 seconds. And then, of course, the V-scan allows you to operate and stop the cine loop through its location on the handle. All right, so what does this look like between individuals who have a healthy ankle and those with a chronic ankle instability? So here's our healthy ankle cine loop on the left. Again, you have the talus and the fibula, and you can see the intact ATFL versus the chronic ankle instability. Here's your talus, here's your fibula, and you can see a whole lot more movement happening on that video, that cine loop on the right. So we can appreciate the instability, we can appreciate the laxity here, these videos, but we still can't quantify it, right? This is where we're getting a little bit of challenge. Sure, we can draw lines where we think the maximum distance is, but it'd be nice if we had an additional way to track the bones and actually assess the amount of displacement that's occurring between the talus and the fibula throughout the anterior lateral drawer test. And so that's where we've brought in one of our other postdocs, Matthew Bloomquist, who's done a really nice job developing algorithms for bone tracking, where we're able to track the talus on the video and the fibula, and not just the talus, but the actual consistent points on the talus. So we're able to follow the same points to ensure that we're actually locating and making our measurements from the same points on the bone. Now, again, you can see in a healthy ankle, minimal displacement here on the left. As the force is applied, we might get close to 0.5 millimeter, but not very, very much beyond that. Whereas the chronic ankle instability, again, we're tracking the bones very nicely throughout the acquisition or throughout the reverse anterior drawer test. And again, you can see displacements happening upwards of 2 to 3 millimeters throughout the applied load. And so we can track displacement over time throughout the entire aspect of the test, but ultimately we may be most interested in where that peak is. Now, when we did this on a variety of individuals that are kind of a little bit of piloting of this approach, how does this compare? How does the clinician grading compare to the actual measurement of displacement through this ultrasound technique? And so these were 13 individuals where we did some pilot work on. And these are sorted from lowest amount of displacement to the highest amount of displacement, a little over 3 millimeters. And again, as we'd expect, some are very healthy and show very little displacement or laxity. Some have a history of ankle sprains, and certainly are going to show more persistent laxity over time. Now, the interesting part is we again had clinicians, one physician, one physical therapist, perform the reverse anterior drawer test and provide a positive or negative grade to it. Now, this is, I think, is kind of an interesting piece, is if we then overlay the clinician grading onto those amount of displacements, it's really interesting to see how the clinician assessed a positive or negative score relative to the actual amount of graded displacement. So no surprise when we get out here to those who have high amounts of displacement, both examiners graded as positive. And just like at the opposite end, those who had very, very little amount of displacement, both clinicians graded as negative. But then there's this middle ground region that's kind of an interesting one where some may have graded as positive or negative. This one down here had very little measured displacement, but both clinicians graded as being a positive test for instability or laxity. This one, of course, showing closer to 2 millimeters of displacement, which we would say is more than typical and is true for a true amount of laxity. Uh, Yet only one of the individuals of our clinicians actually found it as being negative or positive. The other graded it as negative. So some interesting middle ground here to be able to use this to almost to train individuals a bit more as to what may be positive or what's maybe negative, or also for us to better understand what other factors might be contributing to these assessments of how the clinician grades these relative to just true displacement of the bone. So this is actually part of an ongoing project that we're launching, that we're actually, I shouldn't say launching, we're in the middle of at this point, where we are following a couple of different NCAA programs, both men's and women's teams, instituting a number of different biomechanical measures and imaging approaches, as well as survey tools relative to a number of different injuries, but in particular, ankle sprains being one of them. And we have an affiliated program with Technical University of Munich, working with some adolescent development programs in basketball over in their group. And so that's where the development of this technique really was part of this program, was how can we measure the amount of ankle displacement that these individuals may display at the beginning of the season, given their history of different ankle sprains, and how does that change, if at all, over the course of the season, and actually allow us to understand their risk for other injuries that may develop during the season. So a couple things to note, just looking at some of our early data from just from one of the sites, we have 29 Division I collegiate basketball athletes. Then you can see the amount of maximum displacement shown on the y-axis. So we're seeing anywhere between, a half a millimeter up to about 5 millimeters is what our measured amount is. And you can see those that have been graded clinically by again, by our clinicians who are performing the test, the amount that are shown negative, and the amount that have been graded as positive. Again, a lot of overlap between those that are negative and positive, but clearly we're seeing a shift toward, on average, those who are as graded as positive as seeing a greater amount of displacement that is typical through this ultrasound test. Now, how does this also relate to the athlete reported or the athlete perception of their own instability? So using the CAT score, the CAIT score, the Cumberland Ankle Instability Tool is shown here on the x-axis. On the y-axis, we have our maximum displacement measured using the technique that we just described. And then on top of it, we overlaid the clinician graded negative or positive scores as well, whether it's a plus sign as positive, an open circle as being negative. Now, generally speaking, this little gray shaded area is the area where people start to get concerned that they truly do show a level of instability on their CAT score. And so we see there those that are above a 27 or above a 25, depending on what cut score you're in. You can see that sort of distribution. And again, some are showing positive values on instability, yet show really good athlete perception of ankle stability. The lower the score, the greater instability that the athlete perceives. And again, you can see that distribution of high displacement up in this region is actually represented pretty uniformly across all of the different CAT scores that are being developed here or being shown in this particular set of data. Now, again, as we see with those who have lower displacement tend to show better Kate scores as well. But again, the distribution is very interesting for us to be able to build upon and understand more so. Now, when we model the data and start to look for some level of statistical relationship, absolutely, we do see that to be present, and that greater ATFL displacement is related to a worse Kate score. We expect that to be the case, and it shows up here through our modeled measures. But also, when we differentiate between males and females, you can also begin to appreciate that there's generally greater ATFL displacement on average in females compared to our male athletes. Now, again, a number of different factors that could be related to that explain or influence that sex relationship, which we're currently exploring at present. But interestingly, if we go back to the amount of displacement, those who have greater displacement but pretty high Kate scores, one of the variables that tends to influence that relationship uh, tends to be how big the ankle EVER muscle volume is. So when we assessed muscle volume through MRI techniques to be able to show the size of these muscles throughout the lower extremities, what we found is that athletes, male or female, athletes with greater displacement yet high Kate scores had higher ankle EVER muscle volumes, which again makes sense. So they're able to uh, adjust or account or cope with that extent of displacement that they're experiencing or laxity they're experiencing in a functional way through the use of their muscle strength and the neuromuscular recruitment patterns. So again, kind of our big takeaways at this point, the ultrasound imaging seems like or does definitely have value toward understanding the extent and the quality and the severity of the injury. And now we're starting to show promise where we can begin to quantify the extent of displacement or laxity when performed at the right point in time. And the advantage of this is this is something that can be reassessed on multiple occasions, right? It can be done at point of care. It can be done again, a handful of days post-acute injury and done and repeated again as we're getting the athlete closer to return to play, whether it's toward partial return or full return. We can begin to reassess this on multiple time point and even make it part of a baseline assessment at the beginning of the season, at the end of the season, to be able to see how these values change, if at all, over the point of time. And then how do these relationships compare to how do these injuries rather and laxity compare to risk for other secondary injuries down the line, whether it's tendinopathies, muscle strain injuries, or other repeat ankle sprain injuries. Thank you.
Thank you, Brian. Very much appreciate that. If there's any questions, please go ahead and pop those in the chat. We can go ahead and get those answered. I know a couple of them came through from a couple different channels here, Brian. So just to kind of kick us off, could we see this applied to other ligaments like the deltoids, for example?
Yeah, no, that's a great question. I think the key to be able to utilize this for other ligaments is to, one, be able to keep the probe positioned fairly stable throughout the test. And then two, to have a good physical exam test that works well to stress that ligament. So the doing it for the deltoid ligament, I think, will be a little bit more of a challenge, just given the bony congruity to that region and oftentimes the challenges of getting a good stress test essentially performed to it. Not that it can't be, but it would be a little bit more challenging. I think the calcaneofibular ligament, for sure. I think that will work quite well. I think there's an opportunity to use it for um, the anterior inferior tib fib ligament, but then even looking at jumping to other ligaments, whether you're talking at MCL of the knee, LCL of the knee, UCL at the elbow. I think there's an opportunity here to really start to explore additional applications of this technique. Again, I think the important part will be that the post-processing element, as you saw from the talk, there's an aspect of capturing it at point of care and capturing it well. And then there's also the need to be able to quantify it. It can be done in that post-processing manner using the bone tracking algorithms.
Excellent. Great feedback. We have a couple questions popping in. One question is, what's the feasibility of using this? This involved two individuals kind of doing the scanning here. How could you perform this test alone in the clinic? Is that feasible, or kind of two bodies needed for that?
Yeah, no, it's a great question. I think because of the ability to get a rigorous physical exam test, such as the anterior lateral drawer test, that really does require one examiner and both of their hands are being occupied. And so on top of that, then you need someone to be able to hold the probe and hold it in a consistent manner. So it generally will need two individuals to be able to capture this in a valid and reliable way. Um, and so that is one of the extra pieces of it. But again, it doesn't need to necessarily be someone highly trained in it. The clinician ultimately, actually, I think, should be doing the special test because that probably takes a little more of the nuances in performing in assessing the ankle laxity or displacement. Once the machine and the ultrasound settings are all dialed in, then it's just a matter of holding the probe in a consistent position. So a medical assistant or another individual from clinic practice can be able to assist in holding that probe steady throughout the movement.
Excellent. Ultrasound is always a team effort, right? And we love being able to
Absolutely.
get more folks involved. So definitely involving different groups of ultrasound is excellent for us.
Yep.
We had a question here with bone tracking application. Is that something that's added on the back end or a live setting similar to PDI to give real time information?
Yeah, so at present, the bone tracking is added on the back end. So it's not actually integrated at present into the current systems like PDI is or other techniques that people are more familiar with using on their point of care ultrasound. The bone tracking is done post-processing wise, very quick. It doesn't take much time, and we're currently working to be able to see if this is something that can actually become more point of care brought into the unit to be able to be assessed very very quickly at the time where the image is captured and just becomes part of the image capture processing all in real time.
Excellent. We have a couple questions here that I think are kind of related here. Do you use this information to help guidance an expected return to play for athletes? And can we discuss a little bit how we correlated the information we attained from the exam with treatment options and how that varies from prior non-ultrasound recommendations?
Yeah, that's a great question. So, I mean, at this point, when we think about capturing this information, let's say we capture it at 4 to 5 days. There's obviously a lot of care that has to happen before 4 to 5 days for that athlete. And so whether that's early mobilization, whether that's, some level of icing, although as you'll notice back to those guidelines, icing by itself, icing into mobilization is kind of, being pushed away. It's really more ice in combination with mobilization and early movement, early loading is definitely the goal. So that will continue as is. I see this as being allowing us to be able to potentially refine better some of what we may do in our load progression, how quickly we may load individuals, or how slowly we may hold them back, or certain planes of movement of loading where we may hold back before we advance them based on some of the displacement and laxity measures or some of the ideas of, again, making sure that taking this in combination with, for example, some of the everter musculature that we talked about as being copers. If you don't do an MRI to capture muscle volume, you could certainly do a cross-sectional area assessment of the everters through ultrasound. And that becomes, again, an idea of, do we need to build up this person's capacity for everter force production? That again we still have to think about their ability to recruit it quickly and their timeliness of it and their rapidness of being able to react to various levels of instability during different tasks. But I do see this information as helping refine what we currently do. I don't think it's going to drastically change it, but I think hopefully it will allow us to be able to identify those who are at greater risk of CAI or that chronic ankle instability, or ultimately a greater risk of re-injury, and be able to come up with a more nuanced progression of rehab.
Excellent. I think this is a great question to have with the Badger Athletic Performance slide up here. Are you collecting repeat data at the end of the season, or are you just doing that after an injury? And do preseason data influence training programs, return to play, things like that?
Yeah, great question. So our plan is, so we've captured pre-injury as part of this particular research project. We will measure that again for individuals who sustain an ankle sprain. And then we will measure it again as they get cleared to return to play and at various times throughout their rehab program. And then lastly, the entire battery of individuals will have a repeat measure taken at the end of the season. So we'll be able to get a sense of what are the demands of training on these individuals, because we'll have their training load data through Connexon, Catapult, or similar that will allow us to look at exposures. We'll look at training load on the individual athletes. Even in the absence of an injury during the season, maybe just the amount of training load that they're under might end up influencing some of these measures. Um, that of course, any sort of repeat testing begs the question of, well, how reliable is this? And so we've actually done internal reliability testing both within examiners and between examiners, and we've shown very good consistency of that. I think the more examiners we bring into the using this technique, I think we certainly need to expand that further and establish it in a more robust way. But I think that there shows very good consistency within the individuals who are currently part of this study that we have ongoing.
Excellent. Well, I think we've answered most of the questions we have here in the chat here. If there's anything else that anybody who is attending has questions on, please go ahead and pop those in. We have a couple more minutes left. Just as kind of a wind down here, we really appreciate everybody joining. We love being able to provide educational content like this in partnership with AMSSM. We're really looking forward to a lot of other opportunities to kind of get in front of you later on in the year. We're going to be present at the course in South Bend. That's going to be taking place in January. We're very excited for GE Healthcare to be exhibiting at the national meeting in Seattle this year as well. So if there's any questions, we can go ahead and pause, make sure anything else can get asked. But if not, Brian, we really thank you for your presentation today, all of the wonderful content and everything you're doing to kind of advance this space. I'm really looking forward to seeing how ultrasound can help guide the future of human performance here.
Yeah, thanks, Mark. Thanks for the invitation. Very much appreciated.
Of course. Well, everybody, thank you very much. Appreciate you joining us. If there's any other questions, please pop them in the chat. If not, we look forward to seeing you soon at an AMSSM event. And thank you to Brian, UW-Madison, and Badger Athletic Performance for all the great content today. And thank you for AMSSM for hosting us. Thank you, everybody.
Thanks, everybody.